All right, Dr. Jacobson. So this is exciting. I get to have you for part two of our discussion. We did the first one, which you have on your website. I have it on my YouTube, which was really informative. And today I want to keep it kind of basic so that we can touch on some things that I hear my female clients and the women that I talk to when I travel around and run my business, what the things that they ask me, tell me, things that their doctors say to them, which is always very curious. And I want to touch on what a woman should be doing at certain stages of her life and how she should talk to her doctor and ask questions and what each hormone does, and really just dive into it a little bit so that people get some really good solid basic knowledge that they feel that they understand. That's not too sciencey or too medical ease and all that. So first I want to introduce you. I think you're amazing, but I'm not biased because you're my doctor. So I've been on, I think it's almost going into almost 2 years. In the fall, I think I'll be on my hormone therapy, and it's really been amazing. And I know I still have much more I can do with it, and I know we're working together on that. So it's been awesome. And you are an OBGYN initially by trade, yes?
Correct.
Delivered
40
a lot of
years,
babies.
lots of babies.
Lots of babies. Actually, one couple of my clients were like, he delivered my kids. So I know that. And then I know your practice evolved into helping women more with hormonal issues. You said the last time as your patients that had babies with you started to come in later on in life and go, okay, these things are happening. What's going on?
Right.
So I know that you turned your practice into hormone therapy more, and that you studied under Dr. Neil Rougier with WorldLink Medical. I know you're
Correct.
also affiliated with A4M, which is the American Academy of Anti-Aging, which I've attended a lot of their stuff, and I've attended Dr. Neil's stuff. So tell us a little bit more about your training, if I missed anything.
Well, the story goes, I'm always very proud to say this. I give a lot of credit to my wife, and
Excellent.
she is the one that pushed me into hormone replacement therapy because she kept on telling me as my practice was evolving and as I was getting older that there weren't many doctors out there that showed much of an interest in hormone therapy and for the women's needs into perimenopause and menopause. And I reluctantly went to a conference or two along with her, and my eyes opened. And if it wasn't for her, I wouldn't be practicing the way I practice today. So she gets full credit. Um, it takes a lot of time and effort and going and getting different perspectives from different specialists in the country to be able to evolve your practice into what it is. Uh, Many doctors will very simply, if they practice hormone replacement therapy, will be very simplistic about it with a topical cream or patch and a progesterone pill. And once somebody feels better, they leave it at that. Doesn't require much monitoring. And quite frankly, I think that's terrific because for a woman that doesn't have that opportunity, she's really going to be miserable. So they're really doing a service. But there's a lot more that can be accomplished. Um, and so my training is primarily with WorldLink Medical. I'm board certified OBGYN, but I'm also advanced certified in hormone replacement therapy, which takes a lot of effort to achieve. And that's basically the story. I've changed my practice from a office management practice into strictly telemedicine, which I guess that occurred with so many people over COVID. But the nature of this practice lends itself to telemedicine. It really works out very well, and the outreach is phenomenal, and it has been working extraordinarily well over the last 2 years.
So when you started your practice with more hormone therapy, did you find that you had a lot of women coming to you that were past patients, but then were maybe referring like their friends? Like, was it a slow buildup, or was it like a big influx once you sort of hung that shingle, like this is what I'm doing now?
Well, I had the opportunity of dealing with many, many patients who I've delivered and they were providing gynecological care for. And then as they started to have the symptoms of perimenopause or climacteric, I worked closely with them. They would refer friends. The more interesting thing is that once women achieved, or patients achieved really good results, all of a sudden their partners or their husbands were coming in saying, I want what she's got,
Yeah.
because they were impressed by how they felt. And that's how I evolved my male aspect to my practice, which is in the minority at this time, but it's still very, very significant. So it did expand. And
That's
then right now, most of my practice is word of mouth.
okay. And I want to talk a little bit too about your license in the Northeast area. You said Connecticut, we're in Connecticut, New York, New Jersey, Rhode Island, Massachusetts, and you said you
Cal-
registered, or you're also,
California,
okay, and then you're
California, and
registered.
I'm registered to practice telemedicine in Florida as well. Unfortunately, because of the laws of the land, doctors can only practice in states that they're licensed in. So I unfortunately have to turn down people from states not in that group, or have to refer them to other people or organizations that practice the way I practice.
Okay, and also too, just for the note, and I'll put it in the notes too, that if someone's looking for a practitioner that you're not licensed or registered in, they can go to the World Link. I think it's the World Link Health Organization. I'll put the website so that they can click. You can just
Yeah,
easily add in your zip code, and it'll kick out providers that
exactly.
offer hormonal.
We're not the only way to practice hormone replacement therapy. There are many, many different ways, but we're extremely academic. We base our treatment on studies that have been provided in the literature that prove cause and effect of a good outcome. So it's just not anecdotal treatment. So it's very, very strongly bad. And the reason I say that is that a lot of the treatments are contrary to what general medicine, general the medical profession thinks is correct, and you do get some pushback. But the fact that you can, excuse me, we can refer back to the studies makes it for a very strong way of practicing medicine.
Okay, I think what I'd like to do is talk about the different hormones first before we talk about questions that a woman should ask her doctor, so that the listeners sort of will understand what their hormones do, because everyone, I mean, they know the names, but not everybody is like, I don't really know what progesterone does. I just know that I lose it as I get older. But talk about estrogen first, right? And
Sure.
what it does for us. There are three different types, and when do we start to lose it? What does it do for us? What's the problem when we lose it? What happens as we age? I think that's important for us. We could start with each one and sort of go through that, do like a little hormones 101.
Sure. So estrogen is a predominant hormone in women, especially during the reproductive age. It clearly defines your secondary sexual characteristics, your femininity, and your sexuality. I don't have to tell you that.
Mm-hmm.
But from a medical standpoint, it is highly protective against heart disease and stroke. It's protective against dementia. It protects your bones. So what happens when you transition into menopause and you lose estrogen? Well, all those protections are lost or become lost. Women can lose 20 to 30% of their bone strength within just a couple of years into menopause. They have the same risk of a fatal heart attack, not fatal, a heart attack and stroke as a man 5 years into menopause. So it all depends on how you take the estrogen and the form you take it and the dosing that you take it. So it's taking estrogen doesn't always mean you're going to get all those protections. You have to, again, look at the studies. So when a woman transitions to menopause, it's basically the time from when she's having regular menstrual period, whatever is regular for her, until she ceases having periods for over a year. The definition of menopause is clinical. It's a whole year without a menstrual period. Any changes that occur from regularity to that point have different names going through the changes, perimenopause, climacteric, they're all the same. Okay.
Mm-hmm.
And it's different for every single person. The average age of menopause in the United States is 51 years of age. So it's a bell-shaped curve. Many women will be menopausal at 43 to 44, and many are still having their periods at 57 or 58 years of age. So question that I ask patients when we talk about menopause or perimenopause is how old was your mother or older sister when they went through the changes? Because there's a definite correlation. It's not definite, but it gives you a sense. If mom went through changes early or late, you may very well go through it early or late. So if I have to define what are the symptoms of perimenopause, it's all over the map. Professionally, we call it no man's land because it can be anything from skipping your periods, flushes, flashes, night sweats, menstrual irregularity, heavy bleeding every 2 weeks or lasting for 2 weeks, or some combination thereof, not to mention the mood changes, the sleep disorder, and so forth. Very difficult to manage unless you have a sense of how to deal with that. So symptoms, one treats symptoms, and that's what most doctors do, will treat symptoms that I mentioned when a woman is menopausal, particularly sleep disturbance, flushes, flashes, night sweats, mood swings, decreased libido, decreased energy, skin changes, wrinkles, hair changes, and so forth. Estrogen has all beneficial effects on that. Maybe at this time would be a good time to say there are two different types of estrogen replacement. One is synthetic, which has been around for the last 30 or 40 years, and the other is natural or bioidentical estrogen, which comes primarily from plants, yams, sometimes soy, but mostly from yams. I'm only referring to bioidentical estrogens because there's no need to have synthetics. Synthetic estrogens come from animal sources, primarily mare's urine, which is great if you're a menopausal mare, but it's very, very potent, and it's also inflammatory. And
do they still prescribe that or no?
yeah, I'd say still maybe about 40 to 50% of women who are on hormone replacement therapy are still being prescribed synthetic called equine estrogens, most notably Premarin or Prempro, are the proprietary names that are out there. I still get patients coming in with them.
Wow, and they're orals, right? Those are orals?
Those are oral estrogens, exactly. Very inflammatory, very unnecessary. So when a woman goes on her estrogen replacement therapy, it should be gradual so the body acclimates to it. And all of the symptoms that I mentioned, I don't think I have to reiterate it here, are usually addressed fairly quickly. Within a matter of a couple of weeks. It requires some dosage adjustments and so forth. Did you want me to speak about side effects on these things as well at this point in time, or
let's move on to let's move on to progesterone and talk about what that does. Same thing, just so everybody can really understand. Like, okay, this is what estrogen does. This is what progesterone. And then we'll go testosterone and talk about the thyroid a little bit.
Understood. So in the natural menstrual cycle, after ovulation or release of an egg, progesterone is made, and it's made for about 2 weeks. Sorry about that. So progesterone's purpose is to prepare the lining of the uterus for implantation of pregnancy. No pregnancy that cycle, no progesterone, menstrual period. So it's the regulatory mechanism for your menstrual cycle. But as a woman transitions into menopause, as she has deficiencies and then ultimate cessation of estrogen production, the same applies to progesterone. So progesterone is extremely necessary to be taken when a woman is menopausal and she's taking estrogen, but for several reasons. Historically, many women were taking estrogen in high dosages for long periods of time and were developing uterine cancer. So subsequently, all women were getting progesterone replacement with their estrogen therapy. And nowadays, that is actually a very rare event. It's very hard to see somebody getting uterine cancer when they're taking progesterone, but that's not the only reason. The progesterone certainly thins out the lining of the uterus. It prevents overstimulation by estrogen, so it prevents bleeding, spotting, staining. It also protects the heart. It also protects your bones. We know it also protects against breast cancer. And more recently, studies are strongly indicating that it may very well protect against ovarian cancer. That's big. since there's
Okay.
very little out there that protects against ovarian cancer.
Okay. And then how does progesterone also, it also helps people sleep better too? Because I know one of my symptoms was
Mhm.
just tossing and turning and not
Sure.
feeling well rested when I would wake. I would sleep, but I just never felt well rested.
Yeah, progesterone has that major side effect of making you sleepy, and consistently people tell me their sleep is so much improved by taking progesterone. There's an argument that many doctors will tell patients, if you don't have a uterus, if you've had a hysterectomy, you don't need to take progesterone because you
Right.
don't have to protect against uterine cancer. But I've just given you 3 or 4 reasons, important reasons, why you should take progesterone even if you do not have a uterus.
Okay. Yeah, great point. I was going to ask you that because I've heard women say, "Oh, my doctor just has me on estrogen because I had a hysterectomy." I'm
Exactly.
like, "Yeah, but you need progesterone too. It also, helps with your bone density and cardiac health, brain health, all those."
Perfect.
But many people are not, don't do both. But I'm glad you mentioned that.
Mhm.
All right, so let's move into testosterone. And, a lot of women get very nervous when you even just say the word, you can see them recoil a little bit because they think facial hair, I'm turning into a man, I'm going to get a masculine voice. And I think a lot of women sometimes don't realize they may more now, but that we have testosterone and how important it is to us.
Exactly. So everybody knows testosterone is related to sexuality, sexual responsiveness, libido, and so forth. And nature is not very kind to women since there's a natural diminution in production of testosterone from your 20s on out. That's just not fair. But testosterone does more than provide sexual competence, right? Women tend to lose bone strength. I would say 8 to 10% of their, I'm sorry, muscle strength, not bone strength. Their muscle mass diminishes by about 8 to 10% per decade from the 20s on out. Well, that translates out to decreased strength, uh, your endurance goes down, your fatigue goes up. Anybody who spends time in the gym in their 40s and 50s knows that that's the case, and there's a direct correlation to decreased testosterone. Taking testosterone will absolutely reverse all that. In fact, objectively, most women will tell me they see that as the biggest benefit of testosterone. If they go to a spin class, they're spinning like crazy, their tennis game is improved. But it's a very delicate hormone because if you're not delicate with it, yeah, all the things you're fearful of, hair growth, uh, uh, acne, breaking out, irritability, anger, aggression, all these things can be a problem. So it has to be taken care of very, very delicately. There's no cancer associated with taking testosterone. You need testosterone. It also is anti-inflammatory. It reduces what's called visceral fat. That's the layer of fat on the inside of the abdomen that harbors inflammatory proteins. And inflammation is the bane of our existence. It's the cause of it's associated with everything bad, whether it's cancer or heart disease, diabetes, inflammation elsewhere in the body. Testosterone reduces that. It's very important. It also strengthens your heart. Part of testosterone gets converted into estrogen. That estrogen protects your heart. So it's really a wonderful medication, should be on everybody's hormone replacement list.
So two questions on testosterone. First, if a woman really doesn't want to do estrogen and progesterone, just say, could she just do testosterone and would she get some, would she still get benefits? Which,
Absolutely. And I have plenty of patients who either cannot or do not want to take estrogen,
okay.
and they definitely benefit from testosterone,
Okay. So someone could just do like a little testosterone therapy.
unquestionably so.
Okay. And then is testosterone not regulated by the FDA for women to use? Maybe I might not be saying that properly, but why are
It's
so
not
many
approved. It's
doctors
not approved by the FDA.
approved? Thank you. Thank you.
Approved.
So, because,
So we're using testosterone for women. It's called off-label,
okay.
right? So all medications have a specific purpose as approved by the FDA. Doctors, fortunately, can use these approved medications for things that are not approved. It's called off-label use. Legally, it is not a problem. So all women taking testosterone are getting it off-label.
Okay. So if a woman is using, say, a progesterone or estrogen progesterone patch through her OBGYN, could her OBGYN also give her testosterone off label or no?
Absolutely.
Okay. But just some of them, they choose not to, maybe because they don't understand it or they don't know how to dose it or.
Look, doctors can practice any way they like.
Mhm.
And some say, look, I don't get involved in hormone therapy whatsoever. And others are all out and everybody else is in the middle. So it depends on the doctor. And I tell patients when they say, my gynecologist really is not interested, I said, don't leave a gynecologist. You've been with her or with him for many, many years. I'll
Right.
take care of your hormones. Or find
Exactly.
somebody who will provide just your hormone therapy. It's very
Right.
simple.
Okay.
Think of it as needing a subspecialist.
Yeah, absolutely. But I'm sure you probably have come across situations where maybe the doctor, the primary care doctor, the OBGYN is like, I don't want you to do that. Don't, I'm against hormone therapy.
All the time. But, and doctors, like everybody else, are entitled to their own bias and prejudices, no matter how strongly based it is in science. The shame is if they express that towards their patients and influence their patients, it's really very unfair to the patient, extremely unfair.
And does a doctor have to do like more special training in order to be able to treat someone hormonally, like what you went through with WorldLink Medical? Like, is that necessary, or would you say most doctors have the knowledge? They may just choose not to want to practice in it.
I think for basic therapy, like I mentioned, woman comes in, she's menopausal, we've proven she's menopausal, she's benefit from it. I don't think the doctor needs any specialized therapy for that. But understand that treatment, in my opinion, is treating symptoms.
Mm-hmm.
And that treatment will not provide major benefits, such as strengthening of your muscles, if we're talking about testosterone. It's not going to provide much in the way of cardiovascular protection, dementia protection. It will provide bone protection, however.
Okay.
Even low dosages of estrogen given any way, shape, or form can be beneficial to bone strength.
Okay. That's good to know. And let's touch a little bit on thyroid too, because I know that a lot of women will say, "Well, I have an estrogen progesterone patch," and but they're not using a bioidentical thyroid medication that they may need. I think sometimes that gets sort of left out of the discussion.
Well, thyroid is highly controversial, but this is nothing new. It's been controversial for the last 50 or 60 years. And most medical doctors and virtually all endocrinologists will disagree with what I'm going to say, but the body of studies that are out there really support what I have to say, and whether they choose to go along with it or not, that's their position. But basically understand that thyroid hormone made by the thyroid gland is very important for every functional aspect of your body. And if you don't have enough of it, or it's not doing its job properly, then many things can happen. You can put on weight, you can't lose weight, you have fatigue issues, you have dryness of the skin, hair loss issues, constipation, cold intolerance, cognitive problems, brain fog, focusing. These things, or some combination thereof, very, very common. And most doctors measure thyroid function by measuring thyroid hormone and a brain hormone called TSH. And they'll say, regardless of your symptoms, that your numbers are fine, you don't need thyroid hormone. Here's the problem, and this is the way I practice. Thyroid hormone is weak. The body has to convert it to an active form known as T3. And most doctors don't even measure the T3. What I find is a lot of times, tremendous amount of times, their usual measurement, this TSH and thyroid hormone, are in the normal range, but the T3, the active form, is low, at which point I recommend thyroid hormone replacement therapy. Okay? And it's natural thyroid hormone, it's not synthetic thyroid. Natural thyroid comes from pigs and cows. Commercially, you may know it as NP thyroid or Armour thyroid, but it can be made up by a compounding therapist, and it's a combination of thyroid hormone and the active form T3. And it makes a tremendous difference. I have dozens and dozens of patients who've converted over from their standard dose of Synthroid or
Right.
levothyroxine into natural thyroid, and they feel so much better and they achieve the benefits. The problem is by going this route, when a doctor measures their measurements of TSH, the hormones suppress that number, giving the impression that they're being over medicated. And the doctors are really concerned about being over medicated, and they feel that it's inappropriate, and they push back by it. And it's not inappropriate, and it's an ongoing problem because half a dozen times a week, and I mean half a dozen times, I get calls from my patients. I just saw my doctor, and I know the rest of the story.
Right.
So, but I ask patients to go by how you feel. You're not going to be, there's no cancer here. You're not going to have problems from it if you're properly monitored and managed. Most women, I find, are either in mid range or low when it
Right.
comes to the active management of thyroid.
I have, and I hope she watches this. I'm going to have her watch it, but I have a client that has been on the same dose of Synthroid, I think she said for 10 years. And, she says to me frequently that she's having a hard time losing weight and she's not on any hormone therapy. She's a little fearful of it. And, I understand that. I'm sensitive to that. And I'm hoping she's going to call you soon. But, we've talked a
So,
little bit about that because I said, you probably, she's taking Synthroid. And then we talked a little bit about what you just said, how she's, getting more T4, but if she's not converting, she needs to look to see where her T3 levels are. So I'm hoping that she is going to call you. And if she's watching this, maybe this will give her that little nudge.
okay,
But I can
I'll let you. I'll let you know.
but I can speak from my own experience too, as far as being on Armour thyroid now for a bit and knowing that my symptom was I just had that fatigue. It was hard to get out of bed in the morning, which is not my personality when I was a younger girl. But now I'm a little bit older. But that was a big thing for me, and I know that the thyroid has really helped just put that zip back in my step without a doubt.
Right. I must say that most gynecologists are reluctant to treat thyroid. We haven't been trained in that, have been trained in other hormones, but not thyroid. And I usually like to leave thyroid to management to either endocrinologists or internal medical doctors.
And I've also noticed even with this patient I just referred to,
Mhm.
client, not patient, a lot of endocrinologists, sometimes they don't know as much as you think that they would know about some of this stuff as well. And I say that only because my clients have come back to me and said things like I saw my endocrinologist and they said this or that about hormone replacement. They weren't a fan of it, or they haven't adjusted someone's medication for a really long time. So sometimes when they say, "Oh, I'm going to go see my endocrinologist to discuss my hormones," and I'm always like, "Well, you might not get the exact answers or the information that you should
Right.
get." So
Exactly. I agree. I
my
agree.
my opinion. But all right, good. So we went through all the different hormones and what they do. What, in your opinion, say maybe your top maybe 3 questions or so that a woman should say to her OBGYN, say if she's in her 40s? I have to, again, use myself as a reference. No one ever talked to me about hormonal imbalance, perimenopause. I remember my 40s quite well because I'm not that old, but no doctor. I loved my doctor that delivered my kids, but no one ever mentioned to me about anything that this was going to be happening. So it's kind of, and when I look back now, because of all the research and the reading I've done, and I'm talking to you and going to lectures, and I look back into my mid to late 40s and see some of the things that I was experiencing, I'm like, I wish I would have known then what I know now, because I was kind of moody, kind of irritable, not much libido, just tired, kind of cranky. Like I had a lot of symptoms that probably were because I was in perimenopause, but I really had no idea. So what would you say, like what's a good age for a woman to open up this kind of dialogue if the doctor isn't bringing it up or hasn't brought it up? Is it late 30s? Is it 40 something?
I think, first of all, you have to determine when mom or older sister went through changes.
Hmm.
Because they went through changes in their 50s, you don't have to discuss this at 35.
Okay.
Conversely, if they went changes at 45, they should be talking about it earlier, even if they don't feel uncomfortable. Okay. Um, if they have an experience with another friend or relative, maybe their peer, their age, that is going through this, they want to may get some information and should ask their doctor, can you give me some information on this? Send me to a source where I can do some reading about this. And I think you'll bring that up in a few minutes of
Right.
what are good sources for that. Um, as you're considering hormone replacement, clearly the question is, what's the downside? All right. Is there a risk over here? There's always been a fear of cancer, breast cancer, and association. That has got to be discussed. And then talk about the different types of hormone replacement therapy and what's appropriate for you. Not everybody needs or wants all the things we talked about.
Hmm.
Okay? And it shouldn't be limited to either it's all or nothing. It always has to be customized.
Right.
It's not cookie cutter.
Okay. So it depends based on what you just said. It depends on when the person's mother went through menopause.
Well,
Just
it's a guide.
back it out a
It's a
little bit.
guide. Or if they have any question about it. I mean,
Right.
I just spoke to somebody this week. Her husband's 40 and she's 38. Okay. And they're curious because they want the very best for themselves. They want longevity. They want
Right.
quality of life. They know that their hormones are going to go down. They don't have that problem now. Maybe little things, maybe a little get more fatigue. Maybe the focusing is a little off. Nothing really very much. But they want an assessment to see where they stand. And they may
Right.
not need anything after that assessment. But it's not unreasonable to inquire.
Right. And did you do labs with them? Like, would you?
Yes,
Yeah.
yes, absolutely. I'd like something concrete
Mhm.
because, look, we can find things two ways. With the man, he may have great testosterone levels, like it's very reassuring. They may be very low,
Right.
which is not reassuring. And maybe you want to address it now rather than wait.
Yeah, I think definitely being proactive is,
Mm.
I would have done that if I had known then what I know now. And I mean, I think it's just like doing a mammogram or an annual or a colonoscopy. And like you're always kind of doing things to be proactive, to be like, hey, I
Mm.
want to make sure my health stays in check. So I'm going to do all these diagnostics to make sure that nothing
Right.
creeps up on me that I'm not aware of.
But it should be done by somebody who knows how to interpret the information.
Right.
And I say
Exactly.
that because all hormones have a range. There's bottom of the range and top of the range. And the fancy word for everything in the middle is called normal.
Yeah.
But that doesn't help because if you're at the very, very bottom of the range,
Hmm.
yeah, you're there, but that's not helpful. And you may
Right.
feel that as well. And then the doctor's got to be able to express that and show them how they can improve themselves. And that can go for all hormones.
I've had some of my clients say to me, I just did my lab work and my doctor said everything's normal. I'm good. And I'll ask them, well, do you have it? And they're like, no, I don't have it. They just, he called me and said everything looks good. I'm okay. And I said, well, let's get a copy of it. Let's take a look at it. And they'll send over the labs and I'll take a look at it. I'm like, well, this is low, that's low. Like, how do, yeah,
Yeah,
like, what
exactly.
I do feel a little, tired, or I feel like this, or I feel like that. And I'm like, yeah, that's because some of these things you're in the range for sure. But you're, like you said earlier, you're at the bottom of the range. Wouldn't it be better if you were on the other side of the range? You might feel a lot better.
That brings up the topic of the concept of optimization.
Hmm.
Okay. So being in the range is being in the range. But the many of us practice with the concept of optimization. And that simply means when you're taking hormones, you want to know what the hormone level was, what the shit was when you were ideal at 20 to 25 years of age, because all hormones are going south as you get older. Okay. And why is that important? Because if you treat people that way, they'll feel much better. But that's where the statistics start to show that you'll be highly protective against dementia, highly protective against heart disease and stroke, much greater benefits against diabetes, and maybe cancer, not so much. We don't have that much data on it, but this is all evidence-based medicine. It's there. Most doctors either don't see this, don't know it, don't agree with it, but whether you agree with it or not, it's hard to fight the facts. So people just do better when you optimize all your hormones rather than say, well, I'm okay, I'm in the range.
Yeah, absolutely. So, sometimes you want to get your reports and look at them. Granted, not everybody can read blood work, but sometimes you can see, depending on what lab you use, like I know Quest, it's green, right? So where are you in that green area though? Are you on the lower end of the green or the higher end of the green? So I always encourage them to send them over so we can look at them.
The numbers at the end of the day are really a guide. And
Right.
what really matters is, do you feel great and are there any side effects? If there are no side effects, you feel great, the numbers are up there, that's perfect. You don't get caught up with numbers as most doctors do. I'll give you an example. Um, Vitamin D. The
Right.
range of vitamin D is 30 to 100. Okay. There's nothing wrong if you went a little bit over 100. Okay. But if you had a number like 80 or 90, I can't tell you how many patients come to me and they say, my doctor took me off vitamin D because it was very, very high. Nothing wrong with that. Right? You can have 100, 110, 120, right? There are no adverse side effects at that point in time. So, and that's the same for all other numbers too, especially thyroid in particular. Some people require lots and lots and lots of thyroid replacement hormone. I have a couple of women that take very high levels of natural thyroid replacement. I mean, 4, 5, 6 times that you would normally see. The issue is this: they both have chronic fatigue syndrome. They're both feeling better for the first time in their adult lives, and they have
Right.
no adverse side effects, regardless of the fact that their numbers are off the scale. That's
Right.
how I practice.
Right. Individualized, not putting someone into a box or a
Right.
range and seeing
Exactly.
how they feel. How do you feel about saliva tests? I have another client that was working with someone and they kept doing the saliva test, but finally she's, seeing a doctor and doing serum. But what is your opinion on saliva?
I think saliva testing is good for diagnosis the
Mhm.
first time through, but for managing patients on different hormones, I really question it. Um, it's it's certainly not very universal. The standard of care in this country, blood testing, the most accurate form of hormone testing is 24-hour urine collection,
Okay.
right? Which is very difficult to do because you know what's going on. Blood testing tells you at one point in time,
Right.
but the saliva testing usually is more reflective of, I believe, intracellular hormone levels rather than serum levels in the blood. So I don't do it. And if somebody comes to me with that, I'll recommend having blood testing.
Doing the blood.
I don't see it too often, with one exception. That is, if you're doing cortisol testing,
Okay.
that saliva testing is very appropriate to see if somebody has adrenal fatigue, whatever that means.
Okay. All right, so let's shift now and talk about the different types of estradiol that people can use, right? There are patches, there are creams, and there are orals. So, and I know we touched a little bit about the Premarin, Prempro, the mare urine, equine
Mm.
urine synthetic. But let's talk a little bit about how a woman can use estradiol and the different types and why you might prescribe the oral,
Sure.
the bioidentical oral versus a patch, say.
Okay. So we're only talking about bioidentical. We're not
Right.
talking about anything synthetic. And you're right. There's oral, there's topical, there's sublingual, vaginal estrogen, and
Okay.
pellet estrogen. Okay. And I'm a very strong proponent of oral estrogen, which causes a lot of pushback. I will tell you why. When you take estrogen orally, it gets absorbed through the gut, it goes into the liver. Part of it is forms something called free fatty acids, which reduces plaque on your coronary arteries. And the data from that clearly says if you start early enough, you can reduce your risk for fatal heart attack and stroke by as much as 50%.
Yeah, that's
There's
great.
nothing much else on this planet that will do that. Furthermore, if you start estrogen orally and optimized, both and optimized, that you reduce the risk for Alzheimer's disease by 50 to 80%. Given the fact we don't have any adequate treatment for Alzheimer's, that's a pretty powerful number.
Yeah.
Okay. That is only achievable if you take estrogen orally. It does not work if you take it topically, as a cream, as a patch, vaginally, or as a pellet. The
Okay.
pellet is very convenient, but you don't get that benefit from it. So it brings up two questions. First of all, if you take estrogen by mouth, doesn't it cause liver problems? And doesn't it cause blood clots? Well, yes, if it's synthetic estrogen. No, if it's bioidentical estrogen. In fact, a few years ago, I ran maybe 300 or 400 liver function tests on my patients, unbeknownst to them, but it was included in their routine testing, just to prove to myself. And I found only one or two people had abnormal liver functions, and they were both alcoholics.
Okay.
So I'm very convinced that liver function is not a problem. Okay. And as far as blood clots are concerned, the data that I see says that your risk for blood clot on oral estrogen is less than the general population. Now, that's kind of crazy, but it certainly didn't show that you have an increased risk. You
Okay.
do have an increased risk the first year on synthetic estrogens.
Okay. So I want to make sure I understand this correctly. If someone's using a bioidentical oral estradiol, you get the bone, the cardiac, and the brain protection.
Absolutely.
And
And if you're using the other types of other delivery systems of estrogen, you will get the bone
okay, you'll get the bone
protection.
protection, but
Even low dose. Because I have people who are very reticent about taking estrogen.
mhm,
I have women in their 70s starting on this. They don't want to take the usual stuff for osteoporosis or they have failed that. I'll put them on a low dose patch. It's
right.
easy enough
Okay.
for them. They don't have to worry about oral and so forth. And I've seen as much as 3 to 5% improvement in bone density uh, in a year and a half. That's warp speed when it comes to
Yeah,
bones.
that's amazing because a lot of women I've been talking to lately have told me that either through a bone mineral density test or a DEXA scan, that
Mhm.
their osteopenia, that their T score was not so great, or that their mother has bad osteoporosis, or their mother has dementia, and things like that. So, and you hear that. I hear that a lot, and I think it's important
Mhm.
to make sure it's important to have these kind of discussions because I really want women to understand that you know the risks, the myths, not to listen to that stuff. Like get good knowledge because your health could really suffer. You may be 50 something now. Maybe you're like, well, I'm fine. I don't need that. But what about when you're 70 or 80 and then, things start really happening and we're just losing bone faster and faster as we get older?
That's absolutely true. And what is amazing to me is that I have yet to come across one endocrinologist that is recommended as a primary treatment for osteopenia, osteoporosis, estrogen replacement therapy. They're always recommending Fosamax, Actonel, all those medications that slow down the process, which can have a horrendous side effects if you take it long enough. And now they're prescribing a relatively new medication. The name escapes me.
I know.
That does reverse bone loss, but at a cost. You have an increased risk for heart attack. You got to be monitored very, very frequently. You can only take it for 2 years. It's amazing to me that estrogen is just totally poo-pooed and looked over, and it can be a patch,
Right.
and it can be a cream if they're
Exactly.
reluctant to give an oral pill.
Why would someone use a vaginal estrogen? Is that more to help localize with vaginal dryness if sex is painful, or is it just a doctor may just prefer that therapy?
There are two reasons. The primary reason is for somebody who may not want systemic estrogen, total body estrogen, or cannot take it, but has vaginal dryness, discomfort with intercourse, frequency of urination, in which case low dose estrogen is fine. And there are commercial commercially made products for that. Very, very commonly used. It is not absorbed. I think if you did a blood test, you're not going to see much of a change in blood levels of estrogen. Very safe to take, uh, and it's limited. The other estrogen is a higher potency estrogen for women who do not want to take oral estrogen, and they're not getting good absorption on the skin. Happens. You know, you put a patch on, you put cream on, you raise the dose, nothing happening. You give it as a vaginal insert, and wow, all of a sudden things improve. Also, low dose vaginal estrogen is great for women who have recurrent UTIs. Right?
Yes.
Really important also for frequency of urination. The bladder is sensitive to it and it quiets down the bladder quite a bit. Just one small insert every night, especially if somebody's very sexually active and gets UTIs from intercourse. It's really a wonderful benefit.
Is there any woman that would not be a candidate for bioidentical hormone replacement therapy? Like, would you say this would be a woman that I probably would not use hormones with?
Yeah, I think somebody who has active cancer,
Okay.
especially active breast cancer or gynecological cancer, is appropriate. Um, I think so somebody have certain types of blood clotting disorders,
Mhm.
right? And I don't frankly see an issue with taking hormone therapy, but from a medical legal standpoint, it'd probably be wise not to do that. For women who have had a pulmonary embolus, blood clot, uh, be reluctant to recommend estrogen therapy, but they could take, I think, progesterone and or testosterone. I don't see a
Okay.
problem with that. To thyroid, as you mentioned before.
Right.
Then there may be another small subgroup of people who have had problems with estrogen, major medical problems.
And what would you say to those women that you just mentioned if about their bone health? Like, how would they go about protecting their bone density?
That's a real good question. Well, I always hear plenty of calcium, vitamin D, and weight-bearing exercise are important. There are certain combinations, bone medications with strontium in it and so forth.
Okay.
Really, really important. I think progesterone and testosterone would be reasonable to also help them with their bone strength.
Would had some benefit.
Yeah,
Definitely. Okay, no, that's good to know because I'm sure that popped in my head. Then what would they do if they want to have those protective benefits?
right.
And I will reference. I know you sent me an article on different types of estrogen, so I will reference that also in the notes. And on one book, I know you know this because is I always use this a lot because I love this book, Estrogen Matters. I tell all my female clients to either get it on Audible if they don't want to read it or at least listen to it because there is a section in there where he negates so many different things about hormones causing breast cancer. I mean, I think there's one section where he just goes through study after study after study and it shows that estrogen does not cause breast cancer. So,
Yeah, you may want to comment that the author is a medical oncologist, very well aware of the effects of hormones and cancer. And his wife has breast cancer, and she is on full hormone replacement therapy. So interesting.
yeah,
Uh,
no, I found
I
that really
think
extremely interesting. It's a great book and it gives a lot of good factual information. So when women say that to me, I'm not a doctor. I've certainly read and researched and listened and talked to you but I tell them then get this book because it's written by a doctor. So at least listen to that because it's going to give you a lot of good factual information. So,
good.
but this was awesome. I really, really appreciate your time. I know you have other things to do. I could talk to you all day about this stuff, but I know you have a busy practice to run. So is there
There
anything?
is one, excuse me, there is one thing we didn't talk about, but I think it's important, and that is concept of breast cancer and estrogen.
Okay.
Right?
Yeah.
And this is where the concept of observation does not imply causation. And I get this all the time. What does that mean? Well, a patient comes to me and says, I was told I can't go on estrogen replacement therapy because my sister has breast cancer and
Yes.
she has been on hormone replacement therapy for 5 years. Well, the fact that she was on hormone replacement therapy doesn't mean the hormone replacement therapy caused her cancer. And it shouldn't keep you from going on hormone therapy. Women who have BRCA positive can go on hormone replacement therapy. This is extremely important to understand. Estrogen protects against breast cancer, clear and away. Okay, so that's an important point.
That is a great point. And also, if estrogen did cause breast cancer, when we were younger years and had full estrogen stores, wouldn't we see a lot more 20-year-olds or 30-year-olds with breast cancer
Yeah,
if estrogen did cause breast cancer?
you would think. And the paradoxical issue now is for women who are being treated with estrogen blockers for their breast cancer,
Yes.
actually accelerates cardiovascular disease. So what do you, what are you going to do?
All right. So thank you for that discussion. That was really informative. And, we'll get this up so you have it. It'll be on my YouTube, and I will cite the article that you generously sent me and the Estrogen Matters book. And
Okay.
if people are in the states that you practice in, the Northeast and then California and registered in Florida in telemedicine, how should they go to? Just go to GreenwichHormones.com, all one word.
That's it. That's
Okay.
fine.
Awesome.
Go to the website, go to your podcast,
Yes.
okay, and see if there's other things to glean from that, and give us a call.
Awesome. Thank you, Dr. Jacobson.
My pleasure. Thank you so much.
Thank you. Have a good day.
You too, Linda. Take care.
Bye.
Bye-bye.